The next paper is on the pivotal multicenter trial of ultrasound-guided percutaneous arteriovenous fistula for hemodialysis access, presented by Jeffrey Hull.
Good morning. 12 years ago, a colleague of mine asked me, what procedure in your field could be greatly improved by making it minimally invasive? And by that, they meant that it was easier to do, that it was better for patients, and it was less costly. So this is a result of the efforts that resulted from that conversation. So this is the FDA trial of the ultrasound-guided percutaneous arteriovenous fistula for hemodialysis. So for 51 years, we've been making AV fistulas with sutured anastomoses as described by Brescia-Cimino. Despite fistula first and catheter last, we have a difficult problem in getting functional fistulas in patients in a timely manner. The Ellipsys Anastomosis uses a catheter, which is not FDA approved, to create a fistula. On the left, you see the Brescia-Cimino sutured fistula. The Ellipsys Anastomosis is created using tissue fusion, which is nanotechnology that welds the collagen 1A fibers of the artery and vein together in an immediate and permanent connection. On the right, you see the echogenic rim around the anastomosis, and that's dehydrated tissue from tissue fusion. On the bottom, this is a fistula at 688 days, and you see that this connection between the artery and vein are unchanged. So the design of the trial was multi-center, prospective, single-arm evaluation of proximal radial artery fistulas. This was done at 5 sites. All these sites were outpatient office vascular labs. The investigators were endovascular specialists. 7 of them were nephrologists, of course, interventional nephrologists. The efficacy endpoints were standard brachial artery flow greater than 500 ml per minute and a target vein of 4 millimeters in diameter. This was compared against a target goal derived from a meta-analysis of the surgical literature, the lower confidence interval, using one-sided binomial test. Safety endpoint was the absence of device-related serious adverse events. The catheter is 6 French. It's designed to be used under ultrasound guidance and allow the creation of an anastomosis remotely in the body. So these fistulas are created by accessing the cubital vein at the elbow. The patients are getting local and either conscious sedation or a block, excuse me, a block. Let me go back. Try and get this to run. This is a video. You access the perforating vein under ultrasound guidance. There's the needle in the perforating vein. The wire is then advanced. Over the wire, the needle is then advanced to the radial artery, and you can see the radial artery here is heavily calcified, as typical of dialysis patients. Over a wire, a sheath is placed, and then the tip of the catheter is advanced into the artery. The sheath is retracted, and then the tip of the catheter is used to engage that artery wall. The device is closed, and this animation shows how it closes, capturing the artery and vein. The device is activated in 10-second pulses. As it's activated, the jaws of the device completely close, indicating completion of the anastomosis, and you can see microbubbles forming as that occurs. The device is then removed, and ultrasound shows that there's flow in the proximal radial artery, and there's some spasm in the perforating vein. This is simply treated by balloon angioplasty with a 5-millimeter balloon. And this restores the size of the perforating vein and gives a strong flowing fistula. as demonstrated here. Upon completion of the procedure, the sheath is withdrawn and a Band-Aid is placed at the access site. 261 patients were evaluated for the study. 28% did not meet the anatomic criteria, which were 2 millimeter artery, 2 millimeter vein, and 2 millimeter outflow vessel, same as for most surgical trials. 5% of patients were candidates for wrist fistulas and so were excluded. 0.4% failed the Allen's test. Then other patients either declined to participate or had medical contraindications to being included in the study. This resulted in 117 patients. There were 2 training cases at each site, so 10 cases total, and that would be 1 for every investigator. So the investigators had never made an arteriovenous fistula before. That gave us an intent to treat population of 107 patients. We had 98 patients at 90 days and 81 at 360. The patient demographics were typical of the U.S. end-stage renal disease population, other than that there were more men than females, and that was due to more men meeting the size criteria. The procedural characteristics, we had an excellent technical success. 95% of patients got a fused anastomosis. We used the proximal radial artery and perforating vein. Those sizes were 3.1 and 3.5 millimeters on average, but they were as low as 2 millimeters in each case. Procedure time averaged 23 minutes, and the ultimate target vein for dialysis was the cephalic vein in 74% and the basilic vein in 24%. So the result of these interventions is you make a proximal radial artery fistula with low flow. At day 1, the average flow is 334 ml per minute. These fistulas have all the benefits of surgical proximal radial artery fistulas, including preserving vein, giving multiple outflow options, and having a low incidence of Steele syndrome. All of these patients required 1 or more of these maturation procedures. The most common was angioplasty to increase the flow. Patients also had embolization to direct flow either from the deep circulation or from the collateral flow into the target vein. And patients with deep fistulas had them transposed or elevated closer to the skin. On the left, you can see the welded anastomosis between the proximal radial artery and perforating vein. This patient had cephalic and basilic vein outflow. There was about 400 ml per minute in the basilic vein. That was ligated, giving about 900 ml per minute in the cephalic vein and making that an easily cannulated vessel. So the primary endpoint was achieved in 86% of patients versus a target goal of 49% with a statistical p-value of 0.0001. The primary endpoint, there were no device-related serious adverse events. The secondary endpoint, 88% of patients on dialysis actually used their fistula for dialysis. The time to first dialysis, 2-needle dialysis in patients that started the study on dialysis was 100 days. This is a typical appearance of the low to moderate flow fistula created by the Ellipsys device at the proximal radial artery. There's no scar from the surgery. These are cannulation sites, and you can see the appearance of the fistula at 6, 12, and 18 months. So the cumulative patency was 87% at 12 months, and this compares favorably with the literature. That asterisk on here is the Wu meta-analysis of proximal radial artery fistulas, and that they had 80% at 12 months. The functional patency, which is time from first 2-needle access for dialysis to abandonment of the fistula, and it's a measure of how well the fistula works once people start using it, was 93%, and this compared favorably with Hubert's initial description of this endpoint from the Semino fistula group, where they had 88. So in conclusion, we created high-quality fistulas in the office setting. This was done by interventionalists who had never created fistulas before, including 7 interventional nephrologists. I want to thank them for their bold participation in this trial, as well as the patients who participated. From a regulatory standpoint, the vascular access system met the 90-day safety and efficacy endpoints of the FDA trial, and we're hoping for FDA approval sometime this year. Any questions?
Yes.
Hi, Lafayette Stanford. Wonderful presentation. Really great advances in moving this procedure into the hands of nephrologists, so I certainly applaud you. However, I wonder about relative costs of this procedure with a fancy catheter, newly FDA approved, that seems to require in the majority of patients at least a second, if not a third procedure afterwards, and 100 days until you can use it, compared to going to an ambulatory surgery center. Have you started to look at that data?
Which data? The
cost effectiveness.
Okay, so since it's not currently for sale, cost is hard to look at, but cost trials have been done with percutaneous fistula, and they look very favorable. Overall, the intervention rate in this group of patients was no different from the surgical literature.
Have you tried any brachiocephalic or plans to try that? Because many of the patients, especially with diabetes, won't be able to do a radiocephalic.
So this was specifically designed for use in the radial artery. I think conceptually it could be done there, but this trial was limited to the proximal radial artery for safety reasons, really. The proximal radial artery helps control flow. We had very little trouble finding patients that met the criteria. The proximal radial artery is often spared from significant vascular disease.
Yes.
Sharma, San Antonio. Very exciting procedure. Were there any bleeding complications?
Bleeding, no. So there were 2 minor hematomas from needle access, and those were controlled with handheld pressure. So this is, in a procedural sense, this is very similar to placing a PICC line coupled with doing a radial artery access. Once you have access to the artery, the procedure is very simply completed, as shown in the video.
I have a question. Excellent
Yes.
presentation.
Thank you.
Were these de novo or new dialysis patients, or had they had previous accesses before that were successful with this procedure?
Both.
Both?
This was anybody who needed a fistula. So there were, I would say, most of the patients. So 65 patients, almost 65%, were on dialysis at the time that they entered the trial, and 39% were not on dialysis yet.
Okay, but do you know the vintage, how long, average time, the ones that were on dialysis before? Was it years or just months? Or?
It was mostly a mix. It was not. They were not new to dialysis. Lots of patients that had previous fistulas, and I don't know the number off the top of my head. Sorry.
Okay.
Yeah, very lovely presentation.
Jameson?
I just want to ask one additional question.
Okay.
Do you know what the blood flow rates achieved were at 90 days, apart from the fact that you could use them at 90 days?
So the average blood flow at 90 days was 1,000 ml per minute. So I did know that. I didn't want to bore you with all that detail.
Oh, I
yes.
know that.
Yeah. Yes.
I'm Dr. Masakane from Japan. Are there any limitations about the distance from the vein to artery?
Okay.
Any limitations about the distance from the vein to artery?
I think the question is, what's the distance between the artery and the vein where we're making the anastomosis?
Or the maximal level,
Okay.
the distance.
So the distance that we was allowable was 1.5.
Yes.
1.5 millimeters.
1.5
And
millimeters.
what's very interesting, we've done an anatomic study, and 88% of patients have a 2 millimeter artery and a 2 millimeter vein that are within 1.5 millimeters of each other at the site where we make our anastomosis. So we had looked into that ahead of time. So it's very, very stable, very consistent anatomy there.
Thank you.
Good question.
Yes.
Pedro Teixeira, University of Colorado. I also want to applaud the study. It looks like a very promising, cool technology. You mentioned, I believe, in your initial sort of kind of flow of the patient inclusion, that there were either 40 patients or 40%, something of the sort, that were excluded for medical reasons. Can you give us a little bit of an understanding of who those patients were?
Sure. The contraindications for the FDA trial included you couldn't have a transplant, you couldn't be on the transplant list, you couldn't be on Coumadin, you couldn't have cancer. These were sort of FDA-mandated exclusions. So those were the kinds of things.
I have one final question, if there's any others. I wanted you to comment on the average BMI for these patients, and is this feasible for higher BMI patients? I think your BMI was pretty low in this study.
Yes. We've done it in patients with high BMIs. They are more likely to need a transposition just because those veins tend to be deep. There's no difficulty in doing deep vessels with this technique. It makes it a little easier. You have a little more room, actually.
Okay, great. Thank you very much.
You're welcome.